Hello.
Hello. Good afternoon.
I'm trying to make sure that my chat feature is like where I can see it so that when I'm presenting, I can follow along. All right. Well, it's time to get started, so I'm going to do that. My plan is to go over acute kidney injury, a little bit of the kind of underlying pathophysiology for review, talk about a couple of key points for acute kidney injury leading into end-stage renal disease, and then talk about kidney transplantation a little bit, and then show you a video that I like, and then give you a case study to work on. Hopefully, my goal is for the first part to take about an hour, and then give you I don't know, like 20-25 minutes to work on the case study in a group and then present on that when you're done. Is there any questions that I need to address before we get started?
I had one, but I lost my sticky note, so if I find it, I will ask you later.
Okay. All right, is everybody seeing my screen with PowerPoint on it?
Yes.
Yes.
Okay, great. So I'm going to start out with a question that there's no polling opportunity for this. My polling situation was a bust, but here's a question for you. Anybody want to answer the question or talk about why? Type it in the chat.
I'm thinking C, due to the fact that she has bleeding in her urine, or blood in her urine.
Why is the blood in her urine worse than something else on this list?
It indicates that there's trauma that you can't see, so you'll need to take care of that.
Yeah, I agree. Does anybody disagree with C, or did anybody have a different rationale?
I was thinking A, only because we would expect that if there was some sort of like bruising or damage, some level of bleeding to come in the urine. And A could be more problematic with an infection and moving on to sepsis and septic shock. So, and since it's not responding to therapy, there's just a higher risk there. So that was my thinking.
Okay. Does anybody have similar thoughts or different thoughts?
I was a toss up between C and D, but C, since the accident happened 2 hours ago, there could be other bleeding that we also don't know about. The urine might just be one side of one area that she might have hemorrhaging in, but there could be other things that she's bleeding into. So I'd probably pick her first.
Okay. Yeah, sometimes these questions pose these like tricky, little quagmires of who goes first, but they're important to do. So this is part of that triage process that we talked about last week. So if you have a patient who has been in a motor vehicle accident, you don't know necessarily the nature of the accident or the rate of speed that it happened, or necessarily the mechanism of injury, but what you do know is she's been in some sort of vehicle accident that was probably traveling at some rate of speed, or there was some rate of speed traveling that hit her. anytime you have blood in the urine, that's not a normal sign, and it can be indicative of a much more significant problem. It could be for a number of reasons, including her kidney being damaged. And we need our kidneys to be functioning fairly effectively in order to survive. So I would choose C on this one. The reason I wouldn't choose A, although I like your thought process, is that she has a recurrent urinary tract infection, which is not good. But we can treat that typically with antibiotics. She still has urinary tract infection symptoms, but she doesn't necessarily have any of the other problems that you were worried about, or those aren't listed here. So I don't see that she has a fever. I don't have any indication here that she has pyelonephritis or flank pain. And in either of those cases, even if she had a pyelonephritis or a flank pain, bleeding in the urine after a vehicle accident would trump that in priority, because like someone else mentioned, we don't know what else is happening in her body. If she's bleeding in her kidney, where else is she bleeding inside her abdominal cavity? Does that make sense? Hopefully.
Yes.
Okay. All right, so a brief review of our renal system. I hope you have spent a little bit of time reviewing this information. I do know that I think you had this last semester. You talked about kidney stuff, so this will be fairly quick, I hope. But we have 2 ureters, we have 1 bladder, we have 1 urethra, we have 2 usually kidneys. The kidneys are located in the posterior abdomen. They're actually behind the peritoneum. They sit just below our 12th rib. And the right one sits a little bit lower than the left, and that helps it accommodate room for the liver. Why that's significant, though, is that when the right kidney is sitting a little bit lower, it can actually be more easily punctured in an accident by that 12th rib, just by the nature of where it's sitting adjacent to it. So it's a little bit more susceptible to injury. Kidneys perform a variety of things, including fluid and electrolyte balances. They regulate acid-base balance. They produce and excrete certain hormones. They provide the ability for our body to excrete waste products. And they do this by the heart pumping blood to the kidney through the renal artery. A lot of our blood goes to our kidney in every kind of cycle of cardiac output. Our kidney normally filters blood at a very steady rate. That's what our GFR is, the amount of our blood that our kidney filters per minute. It does this through our smallest unit here, our little nephron, which has a glomerulus. And our glomerulus is the capillary bed that is the functional kind of property of this filtration process. Besides filtering blood, our kidney, our nephron, our little functional unit of our nephron, reabsorbs electrolytes and water and nutrients. It secretes waste products into the tube. So our nephrons reabsorb from the tubules back into the efferent arteriole, so back into our vascular supply. It also secretes waste products from our efferent arteriole into the tubule. So stuff that's in excess that didn't get filtered can be put back into the tubule for excretion. And then the end game is to excrete anything that's in excess out through our urine as waste. We can assess how our kidneys are doing from a variety of different lab values, and these are some of the ones that we look at. I'm going to talk about a few of them separately, but when we're considering how our renal system is doing, this is the kind of gamut of things that we're addressing and looking at. Our glomerular filtration rate, or GFR, is considered the best overall indicator of kidney function. It's the amount of blood that's being filtered through the glomerulus per unit per minute. A unit of time is a minute. It is controlled by blood pressure and by blood flow. And we need a minimum systolic pressure of about 65 to 70 to maintain enough hydrostatic pressure, that's that push pressure from our vascular system, to push fluid through the filtration process. We need to have that much pressure to filter blood through the glomerulus. Our GFR, the amount that we do this, so the GFR, our rate, decreases with age. And by the time we're 65, it can be about half of what like a typical normal, I'm putting air quotes around normal adult could be. A decline of our GFR is more rapid when there's other underlying risk factors that affect GFR rate, including diabetes, hypertension, or heart failure. So if there's already something that is decreasing the flow or function of our GFR, and we're aging, we can end up with, kind of a fairly rapid decline of this filtration rate. This is why older adults are at an increased risk of delayed drug clearance, because their GFR is just not clearing all of that excess, I'll call it waste material. I know it's not waste material, but all of that excess drug material. So it can be delayed in this clearance process, and the older population can be more susceptible to toxicities. Measuring a true GFR is difficult. It can be done, but usually we estimate this using different measures of serum creatinine, using measures of standard normalizations based on age, race, and gender, and combining those with the serum creatinine level to come up with what an estimated GFR should be for someone with those conditions. And we use that number to represent a GFR. If you're going to measure the GFR from the kidney itself to get a true GFR, it takes about 24 hours to be able to get that measurement accurately. And usually people don't have that kind of time. Sorry for the spinning. I didn't know that was happening. The BUN and creatinine are frequently seen as these measures of kidney function, and they are both important. So I'll start with creatinine. Creatinine is when muscles metabolize, they make creatine, and creatinine is a byproduct of creatine, of muscle metabolism. It is then readily excreted by the kidney. There is no that's small enough to pass through the glomerulus. And it also gets excreted by the efferent arteriole into the tubule. So anything that's in excess is readily excreted out into our urine. It is normal to have creatinine in our urine, and we should. We have a very kind of constant low amount in our blood. So our serum creatinine level stays fairly constant because we can just readily secrete the creatinine through our urinary system. Because of that, it becomes a really good measure of our serum creatinine, becomes a really good measure of how our kidneys are doing. So if our serum creatinine is elevated, it is a good indication that something has happened with our kidneys, because it's not readily excreting this thing that it normally readily excretes. The blood urea nitrogen is a byproduct of proteins being broken down into amino acids. And there's normally a small and stable amount of urea and nitrogen in our blood. But when the kidneys are malfunctioning, or they can't excrete excess waste, which urea and nitrogen are, they can increase in our blood. So we can use these as a measure. It has a limitation because the BUN can also be affected by liver problems. So, and whether or not liver is metabolizing proteins or not. And so while it does help us identify renal problems when the BUN is elevated, it is not specific necessarily for the kidney. We often see this as a ratio, the BUN to creatinine ratio. And these are both BUN and creatinine are indicators. They're kind of like indirect indicators of RGFR. The ratio can be helpful if you see a BUN creatinine ratio. It can be helpful when we're looking at acute kidney injury and determining what kind of acute kidney injury is present. I think that's kind of when that is mainly used. We can talk about that in a little bit if that's not clear. A BUN creatinine ratio will be typically greater than 20:1 in pre-renal failure, which we're going to talk about. And if you have a intrarenal or post-renal failure, the BUN creatinine ratio is usually less than 20:1. We also look at the kidney itself to see how it is functioning. We can do renal ultrasound to look at the size, the shape, the location, the flow of the kidney. Certainly CT scanning can help. X-ray is a very cursory way just to look at the kidney size inside the body and location, but it isn't particularly helpful for flow if we're worried about a acute kidney injury that's related to glomerular issues. And then of course we can biopsy the kidney, and that gets done again to determine the histology of the kidney itself. So what is the actual problem? Is if it's an intrarenal kidney injury, is it the problem of the nephron? Is it a problem of just the glomerulus? Is it a problem of the tubule? And so that's where a biopsy could be beneficial. There are 3 types of kidney failure or acute kidney injury, acute and chronic, and you can also have an acute on a chronic condition. An acute kidney injury is referring to a rapid decrease in the ability for the kidney to filter the blood. It's usually within hours to days. And if the kidney is not filtering our blood, then that can lead to our demise. So we are recognizing when this is happening fairly quickly. Chronic renal failure is progressing much more slowly over months to years. And someone can have a chronic renal failure and then have an acute kidney injury on top of that. And of course, that just how it sounds has a much worse prognosis because it does have a much worse prognosis. End-stage renal disease refers to 95% loss of renal function. Chronic kidney disease inevitably ends up at end-stage kidney disease. The rate at which that happens really depends on the underlying issue, condition, and any other, kind of comorbidities that may be affecting kidney function. But chronic kidney disease into its full end game either requires dialysis, renal replacement therapy, or a kidney transplant. Acute kidney injury, we'll talk about that too, can lead to a chronic kidney disease. It can also bypass chronic kidney disease and skip straight into end-stage kidney disease or renal failure, complete renal failure. There are 3 main causes for acute kidney injury. The first one is perfusion or decreased perfusion to the kidney itself. The second one is damage of the organ. And the third one is an obstruction to the outflow, which creates a backup of fluid or waste products in the kidney, therefore damaging the organ ultimately. Many, many cases are pre-renal, and so we'll talk about that first. So pre-renal acute kidney injury is some sort of decreased perfusion to the kidney. So what sorts of things would cause a decreased perfusion to the kidney?
Shock for any reason.
Yep, shock for any reason. Kind of sums it all up. There's other things besides shock, but yes, certainly. Anybody think of something that's not shock necessarily or not shock yet?
Kim said heart failure in the chat.
Oh, thanks. Yes, Kim, you're correct. Heart failure. Mhm.
Aortic aneurysm.
An aneurysm? Sure. Yep.
Dehydration.
Yep, dehydration. Mhm. So heart failure isn't necessarily cardiogenic shock, but an aneurysm, a ruptured aneurysm, is probably going to lead to some sort of hypovolemic shock, and dehydration, same thing, is going to lead to some sort of volume problem. An aortic dissection would certainly cause a hypovolemic or shock type scenario, causing decreased perfusion for sure. It can also be something, though, that affects blood flow to the organ itself. So it doesn't have to be that the body doesn't have to be in shock or necessarily in low volume, but there could be something that's preventing blood flow to the kidney. So if you had a clot in the renal artery, for example, that could do it. And if you had really bad arterial sclerosis of a renal artery that eventually, occludes or gets to a place where it is not perfusing the organ itself, you could see acute kidney injury, a pre-renal acute kidney injury that way too. I think the takeaway here is that pre-renal failure outside of an underlying chronic kidney disease, in pre-renal failure, the kidney is otherwise healthy. There isn't something wrong with the kidney itself. It's just something wrong with getting flow or blood flow to the kidney, but the kidney itself, the organ, is fine. That certainly is not the case, clearly, if it's an acute on chronic condition. If tissues don't get blood flow, they become ischemic and they can die. And so this is sort of my schematic of pre-renal failure as it relates to the glomerulus. So pre-renal failure can occur as a result of actual volume loss, which we talked about how that can happen, and then effective volume depletion, which is if there's just some sort of limiting factor getting blood flow to the kidney, but not necessarily to the rest of the body. Either one of those situations, if there's decreased blood flow to the kidney, the glomerulus recognizes this as a problem. The glomerulus is very needy, and if it doesn't get a certain amount of flow, it gets upset. And its response to being upset is to activate the RAS system, which tells the kidney to conserve sodium, and by conserving sodium, it's going to conserve water. And so the goal here from the kidney's perspective is to increase the vascular volume. If it resorbs water from the body, or sodium and water from the body, there's more volume in the vascular space. There's potentially more volume getting to the glomerulus, and the glomerulus then becomes happy again because it has more pressure to filter the blood from. So if you have decreased GFR because you have lack of flow to the glomerulus, you end up with this accumulation of waste products in your blood. This is sort of my schematic here, but the decreased GFR is going to lead to RAS activation for the reasons I just talked about. And because we are activating the RAS system and we're reabsorbing sodium and water, we will have inherently a decreased outflow of sodium and water in the urine. So we end up with oliguria. This is not always the case, but this is the case for this situation that we're talking about. Because we have a decreased GFR, we are also not secreting excess waste products into the renal tubules. So we can have an excess of potassium in our blood, and we can have an excess of hydrogen ions in our blood. So we can end up with metabolic acidosis as well as a hyperkalemia. We also need to secrete excess nitrogen and urea, as I talked about, or creatinine. And if we're not doing that because our GFR is decreased, we can end up in it with azotemia. So that is this increase of waste products in our blood. There's also the ischemic events of not getting blood flow to the kidney, and that causes further loss of our nephron, and we end up having worsening GFR, which worsens the whole system. If this is not reversed in a fairly quick fashion, we end up damaging enough of our nephrons or enough of our kidney function that we have an intrinsic or intrarenal acute kidney injury that results. We measure oliguria for acute kidney injury as less than, when urine output is less than 400 milliliters per day. If the kidney stops functioning, either because of some internal kidney disease or some sort of injury, or because we have a pre-renal kidney injury, we can have an intrarenal kidney injury where the organ itself becomes damaged. I sort of have here how this happens, so we can answer that question or not. But are there any things that you can think of that will cause damage to the renal tissues themselves?
Drugs,
Kind of.
nephrotoxicity.
What did you say? The second part? I heard drugs.
Oh, I just said nephrotoxicity. I don't know which drugs. The ones that say in their instructions, nephrotoxic, can be nephrotoxic.
Anybody know some classic nephrotoxic drugs?
Gentamicin.
Gentamicin. Mm-hmm. Any others? There's some key ones out there. So certainly certain chemotherapeutic drugs can be nephrotoxic, but even more readily available, NSAIDs like ibuprofen can be nephrotoxic, especially if taken in excess, or taken without enough renal clearance to have, the amount that was taken may have been fine for a normal healthy kidney, but if somebody has a renal issue already and they take aminoglycosides, we have in lithium, if somebody takes too much ibuprofen too soon, so it doesn't allow for adequate renal clearance of the initial dosing, it can cause further renal damage and lead to acute kidney injury of the tissue itself. Another one that we need to consider is contrast medium. So contrast medium is nephrotoxic, and we need to be very, very careful about how many nephrotoxic or harmful agents a person has on board when considering using contrast medium on an individual. You definitely need to make sure that there is an order in place that is checking renal function before somebody has contrast. Because at least initially for intrinsic or intrarenal kidney injury, because there's adequate blood flow, at least in the beginning, to the kidney itself, the RAS system usually isn't activated in this case, unless it's from a pre-renal injury, of course. And that can lead to sodium and water loss, because what's happening is the tubules are damaged and they're not reabsorbing sodium and water back into the vascular space. And so you can actually see quite a bit of water loss in intrarenal injury. And so this is just my example of how things get. You can have infections like glomerulonephritis or a nephritic syndrome or nephrotic syndrome that can be damaging the tubules themselves, or toxins can cause tubule damage. And we talked about some of those. That damage inherently is going to reduce the secretion of stuff from the bloodstream into the tubule, and it's going to reduce reabsorption from stuff from the tubule back into the bloodstream. So while we may or may not see oliguria here, we're still going to see azotemia, acidosis, and potassium increases potentially. The more sad or dead or damaged tubules you have, the worse the renal injury is going to be. Someone is typing busily. Anybody want to speak to this?
Maybe the last one. Maybe it's less concentrated because it's not filtering correctly. Whereas in pre-renal, you're just going to see less altogether, more oliguria. But maybe with damage, it's just not filtering as well. That's my guess.
Anybody else have any guesses or thoughts or agreements or disagreements?
I agree.
You did agree and you still do.
Yeah.
Okay. Anyone else? Maybe I'll take it by the lack of response that everybody agrees. I also agree. I think that's true. Because the tubules are damaged, they will not be doing their job, and we will end up with potentially more dilute urine. Okay, post-renal acute kidney injury. I feel like this is very straightforward oftentimes because it's caused, not just, but it's caused from some sort of obstructed flow out of the kidney. And so what types of things cause obstructions out of the kidney?
Benign hyperpros, BPH, hyperplasia.
Obstruction with stones, yeah.
Yep, kidney stones. You can have strictures from excessive scarring in the
TI that goes up the narrative, yeah, connecting.
What? That was amazing.
Good job, Taylor.
My Zoom's malfunctioning. I can't even chat. So it's just been a morning.
So a UTI in and of itself, not typically, unless it's an upper UTI, it's like a pyelonephritis.
I was trying to say that when it like advances up the urinary tract, when it's starting to becoming risky for like sepsis, and it gets into towards your kidney.
Yeah. So you can have a pyelonephritis, which is when you have an upper urinary tract infection. So like anywhere above the bladder, basically, if you're having a urinary tract infection, it would be an upper urinary tract infection of the ureter. And they do usually transcend upwards, but you can have a pyelonephritis where there is inflammation and infection in the kidney from the pyelonephritis. That doesn't necessarily mean you're septic. it can cause problems down the road if it's untreated, but just pyelonephritis does not equal sepsis, but it does equal an infection that's in the kidney from obstructed flow or from bacterial involvement. But if you have a lot of pyelonephritis, if you have a lot of urinary tract infections, you can get scarring and strictures in your ureter, and that can cause an obstruction or outflow problem where you end up with a backup of waste products in the kidney. Tumors, certainly, tumors not just in the bladder, but in places near or around the bladder or the ureter, or even the urethra, that will cause some sort of obstruction from flow out, will create a backup of waste products in the kidney. The tubules, as much as they like to excrete urinary and waste products, they don't like to be bathed in them, and so that can become a problem. It can lead to an intrarenal injury. Thank you, extrarenal tumors. Thank you, Sophia. Okay. I'll speak at once here.
The best I can think of would be D. I mean, surgery to remove the stone is possible, but I don't see how an oral glucose test would have to do with that. So B's out, and it's kind of the same with C, because they don't really seem to speak to normal causes of extrarenal or post-renal failure, unless I'm way off.
Yeah, I think there's some chats for D. I would agree. A chat for D, or D would be the most appropriate response here. Our first, order of business when there's an outflow problem is to figure out where that outflow problem is, and an ultrasound is a very non-invasive way to look at the kidney and look at flow. If there is a stone, which is a common reason why there could be an outflow problem, then shockwave lithotripsy is going to be the solution far more frequently than surgery. We would like to not have to surgerize a stone if possible. Acute kidney injury can be reversible, and the clinical course is similar for all ages. To be reversible, it needs to be recognized early, and then interventions need to be in place early to prevent further damage of the tubules. If it is not corrected, it will lead to end-stage renal disease. And your book talks about RIFLE as its severity index, which measures severity based on serum creatinine or the GFR levels and urine output. And this is basically what your book has in it. So we're measuring who is at risk for acute kidney injury based on two separate measures here, either their creatinine level or their urine output level. And then kind of going down the line with injury, failure, loss, and ESRD. Certainly, if we can intervene in this risk area when we are measuring, renal function in our complete metabolic panel, and we see elevated creatinine, that's our time to intervene before we end up having actual injury. Becomes a lot harder and a lot more problematic for the patient. This is why measuring kidney function before administration of nephrotoxic agents, for example, would be very important to do. These are some common causes in a kind of just a slide here for you. You can see some of the different drugs that can cause problems, nephrotoxic agents, things like that. So rifle starts with the identification of somebody who is at risk. If somebody has a mild decrease in GFR or serum creatinine, then the goal is to prevent or initiate early interventions to prevent further compromise during a hospitalization. One of the things that happens to hospitalized patients is they, even if they're otherwise healthy or were prior to hospitalization fairly healthy, is dehydration. So people get hospitalized and then they stop drinking fluids and they can very easily get dehydrated. So obviously monitoring people's hydration status, especially if you have an older patient who may have a decreased thirst drive anyways, and you have patients who have underlying problems with their kidney at a baseline. So folks with DM or with CKD. There are lots of complications for kidney injury, certainly with any type of shock, as we had talked about before. All of our shocks somehow, will cause decreased perfusion, not just of every other organ in our body, but also our kidney. And so that is a problem. Patients who have heart conditions where it's a pump problem and perfusion to end organ tissues is being compromised can cause injury, acute kidney injury. And a vast number of patients who are seen in the ICU develop acute kidney injury because they just have so many other complicating factors happening. We need to keep measuring and assessing I's and O's, strict I and O measurements, blood pressure, monitoring for blood volume depletion, making sure that if nephrotoxic substances are being used, they are being used because that's the only option and that they are not being used at the same time as other nephrotoxic substances. The more risk factors that someone has, like multiplied on top of each other, the worse the kidney injury will likely be. We talk about urine output as this measure, and I have told you, and it'll be another slide, I believe, as well, about the measurement of oliguria being less than 400 milliliters per day is kind of that initial oliguric phase of acute kidney injury. We certainly don't want to wait to report decreased urine output until we've waited 24 hours and said, oops, last 24 hours it was 400 milliliters a day. I should probably say something. This is something that you want to intervene in early. So 2 hours of decreased urine output should be addressed. We want to assess patients and stratify their risk of developing acute kidney injury. So this is more looking at, well, some of these things, I guess, are more looking at patients who are coming into the hospital for whatever reason they're coming into the hospital. And in order to prevent acute kidney injury based on kind of compounding variables, assessing risk of development of acute kidney injury is going to be based on some of these factors. So kind of a history of recent surgery or recent trauma. Are there other underlying factors that could be affecting perfusion, like a recent clot? Are they already at a baseline dehydrated? Do they have a history of a chronic disease that increased their risk of renal insufficiency? Have they had a recent illness or an infection? Because there's some infections like strep, a basic strep infection in your throat can actually cause inflammation of the glomerulus. This happens especially in children, but it can happen in adults too. Do they have underlying allergies or medications? Are they taking a bunch of nephrotoxic drugs? Are they using NSAIDs daily at their maximum doses? Do they have any history of stones or obstructions? Because when people are dehydrated or stressed, they tend to form stones more, and you can be dehydrated and stressed being hospitalized. And then consider patients who are on NPO status for prolonged periods of time. Because I just said, like, that dehydration can be very problematic for patients who are hospitalized. When surgeons are putting patients on NPO status and writing those orders, they're anticipating a surgery time, right? So they go and they just say, NPO at midnight, assuming that the patient is going to go to the OR first thing in the morning, but 800,000 things delay surgery time. And so for some patients, the surgeons in doing surgery of other people on other problems for other reasons, and now a patient can be on NPO status for an indefinite period of time. And so this is kind of using that nursing clinical judgment to make sure that the providers who are caring for patients are still aware that they have patients who are NPO. Some of these patients may just need IV fluids, right, to manage that, but not every patient gets IV fluids when they're NPO. So just kind of keeping that awareness. We talked about the lab assessment. We want to monitor urine output, of course. And then we used other diagnostic tests to measure and to image the size of kidneys, any obstructions, any tumors. We can see perfusion through different diagnostic testing. In acute kidney injury, the kidneys actually tend to be bigger or more swollen than you would see in chronic kidney disease, where the kidneys tend to be smaller, more atrophied. And then acute kidney injury is a systemic disease process. The kidney impacts all of our other organ systems. And so if there's something wrong with it, we can expect that all of our other organ systems will feel that impact. Let's see what I want to say about this. Not much. We've talked about some of these already, I feel like, but certainly the cardiovascular system will be impacted if the kidneys are not processing blood or fluid and pulling off excess fluid. We can see edema, we can see hypertension for a similar reason, more volume in the vascular space. It can lead to a heart failure. It can be worsened by a heart failure. And if we have hyperkalemia because we are not excreting the excess, what kind of dysrhythmia do you expect to see here? Or what kind of EKG change might you see?
Prolonged QRS.
Not typically.
Oh, I was wondering, I muted myself before I said, is that right?
Oh, they may be tachycardic. So the classic sign with hyperkalemia is tall spiked T waves. Thank you, Cindy. Peaked T waves. These are some measures up in the upper right that can be initiated to remove excess potassium from the blood. Some of these measures work faster than others. When glucose is used in combination with insulin, it can enhance the effect that insulin has on driving potassium into cells. So it's a pretty temporary measure, but it can work fairly quickly. Whereas caxylate is not instantaneous. That often takes some time before it is kind of solidifying or kind of extrapolating the potassium. And so it may not be the best choice for an emergent condition, or not alone anyway. Calcium salts you'll often see used given IV. And then certainly we use dialysis in an emergent situation or for patients who have acute kidney injury. If we cannot manage the excess waste products, whatever they may be in the blood, that is the indication for dialysis to be initiated. have a vote for C. Have any other votes? 2 votes. C.
I think C.
Why do you think C?
Don't they produce erythropoietin?
They do. They absolutely do. Yep. So kidneys secrete erythropoietin. It stimulates the bone marrow to make red blood cells. So if we do not have kidneys that are producing erythropoietin, we can expect, especially not in the very acute time period, but over a shorter period of time, that a patient with renal injury can become anemic. More effects, the neurologic system is affected, uremia, so this increase of uremic wastes can cause problems in our brain. We actually don't like waste products in our brain, and we can appreciate some mental status changes.
Okay, I'm gonna go put you down for a nap.
Thank goodness, I'm exhausted.
No, it's nap time. Okay.
Okay, we gotta mute, even though it is nap time. I appreciate that for me too. Okay, gastrointestinal symptoms. Azotemia, so an increase in waste products in our blood, can lead to GI symptoms of nausea and vomiting, mucosal inflammation. Our gut is responsible for breaking down urea into pneumonia, into ammonia, and ammonia can cause ulcerations and bleedings and also liver problems. I can't find my mute button. Okay, wait, hold on. All right. And then there's an increased metabolic demand. So just because the body is just under stress and working very, very hard. So we have to try to meet that metabolic demand without overtaxing the system as well. These are some things that we would like to do. Certainly recognition early so we can prevent any problems. Also making sure that patients in the hospital are perfused. If we are giving them nephrotoxic medications, because that's the only option, like if they have to have contrast, making sure that we're increasing fluid so that they can clear that faster. It's not sitting, creating further kidney damage. That's often used certainly for other nephrotoxic infusions to make sure that there is significant fluid, kind of just saline or some other type of fluid that can follow that to help push that through the clearance system, whatever it may be. Treating underlying cause, monitoring I's and O's. We're going to do strict I's and O's. For patients who are in acute kidney injury, we usually do a fluid restriction. And this restriction equates to about 600 mLs plus whatever their previous 24-hour output was. So that's where our strict I&O measurements need to be quite accurate. We might restrict potassium since a person with kidney injury is not clearing that very well, phosphate and sodium for the same reasons. Monitoring vitals, daily weights, you can read these things. And then if we need to rapidly kind of clear these toxins from the blood because our other interventions are not working, then we will move into dialyzing them. Acute kidney injury is often discussed in phases. So onset is this phase where between the time that the kidney was injured until the patient starts with their oliguric phase. During this time, there may be a very gradual or subtle accumulation of waste products. This is the R, puts the R in rifle there. In the oliguric phase, it's very early on. It's usually lasting 1 to 3 weeks. If it's from ischemia, it can, and this time period between the onset to when someone is oliguric can be a day. If it's because of nephrotoxic drugs, it may be a week. It just really depends on what the underlying insult was that created the problem in the first place. It lasts from days to weeks typically, and rarely more than a month. The longer it lasts, usually the poorer prognosis for full recovery. I talked about how not all acute kidney injury will experience oliguria. Some type of intrarenal injuries will potentially not.
Professor,
Yes.
it's talked about fluid challenges. Could you maybe explain what a fluid challenge is, or what we do in this case as a fluid challenge?
Where were we talking about fluid challenges? Sorry, here before? Couple back. Yeah, so a fluid challenge would be, you are putting in IV fluids to, oh, here it is, no response to fluid challenges or diuretics. So no matter what you're putting in, you're not getting that out. You can challenge someone with a bolus of fluid, isotonic fluid, or try to diurese them with a diuretic to try to pull excess fluid off. If a kidney was functioning normally, so this is right in this early phase, if a kidney was functioning early, we would expect that if we bolused someone with fluid, that they would have increased urine output. What goes in should come out. If that's not happening, and we give them a diuretic and they're still not peeing, then we know that the kidney itself is an issue here.
So we can do that even with a fluid restriction then?
So typically the fluid restriction is going to start once we are fully aware what's happening with their kidney, that it is truly a kidney problem.
Okay, thank you.
Yeah, and at some point, we may bolus them to see if they have improved kidney function based on our interventions. And giving them a fluid challenge can be part of that. The diuretic phase, usually it's considered a diuretic phase when it starts about 24 hours after the urine volume has increased to greater than 500 cc's per day. What we see is the BUN and creatinine stop rising at this point. It doesn't mean they decrease, but they stop rising. So we are now pulling off some of our waste products, some of our nitrogen waste products, and excreting our excess creatinine. At least we're at least excreting some of it so that it is not continuing to rise in our bloodstream. The kidneys and the diuretic phase can excrete waste, but they can't concentrate urine at this point. And then in the recovery phase, we should note a marked decrease in azotemia. The BUN and creatinine should return to normal or to near normal. The kidneys are concentrating urine now. This can last from weeks to months, but it may never return to pre-illness levels. The functional loss of the kidney, so if you measure their creatinine or creatinine clearance or BUN, it may indicate that there is a slight elevation in those levels, but it may not be clinically significant. They could have a slight increase in the creatinine in their blood because the kidney is just not performing at the exact level it was before, but functionally the kidney is performing just sufficiently. Some patients may continue to progress to chronic kidney disease, and some patients may not recover at all and end up in end-stage renal disease. We're going to treat patients based on whatever the underlying problems are, and then we'll dialyze them. Usually continuously, because they're typically critically ill, they'll be on continuous renal replacement in the ICU. If someone is more stable, they may be on hemodialysis, and they may end up going home on hemodialysis after discharge, at least for some period of time. They'll probably be followed quite closely with a nephrologist, and there may be permanent renal damage. I feel like I've talked about this already a little bit, or enough, but they may need chronic dialysis or just short-term dialysis for the next few months while the kidneys recover, or it may lead to end-stage renal disease where they are needing a transplant. This is often very life-changing for people who, if they are not fully recovering and getting their life back, somebody going home on dialysis will need a lot of education, as well as psychosocial support. It is very life-altering to have to be hooked up to a machine many times a week or every single night. Very different from what someone's life may have been like before they had this acute kidney injury. And so a lot of psychosocial support, family support, and education are needed before they can be safely discharged home, and close follow-up. This is kind of what I've already said. Acute kidney injury leads to end-stage renal disease about 10 to 20% of the time, requiring dialysis or transplant. When the GFR is less than 15, that is when they are in end-stage renal disease. And that's what I have about that. Any questions so far? Okay. Where is? I'm going to share my next screen here. This one's fairly short. Somehow I lose my Zoom screen as soon as I share. Okay. All right, are you guys seeing my kidney transplant screen, hopefully?
Yes.
Okay, great. And I shared this with you already. I'm not going to kind of read through it because you can do that. And I want to show a video about a person who did not have a transplant, and why. But I think it's good to know about transplants in general. And so I'll use this as kind of talking about transplantation. It's come a long way, particularly kidney transplants. So the first kidney transplant was done on twins in 1954. It was actually performed on my middle school teacher with his twin brother. And his twin brother did not live very long after that. My middle school teacher lived a very long, healthy life with one kidney. But we've come a long way from then when donors, live kidney donors recipients now live very successfully in the 90 to 95 percentile range, depending on whether it's a live or a cadaver donor. It is not considered a cure because this person still has potentially whatever the underlying kidney problem was, it could still be present, and they have this lifelong management of being a donor recipient. And so it is considered an extension of quality of life, but it's not actually considered a curative treatment. It is much less expensive to receive a transplant than it is to be on dialysis. But the problem is there's this very large disparity between the number of available kidneys and the people who need them. There are tons of people on waiting lists, and there just are not as many donors available. People do lots of different donation methods, so you can donate to someone, unlike some organ donations, so kidneys and livers, you can donate live donors to live donors or to live recipients, but the criteria for being a donor and the criteria for being a recipient are fairly strict, and so that also becomes a limitation. In some donor pools, if I wanted to donate my kidney to someone that I really care about, but we're not a match, I can put my kidney up basically to someone that I am a match with, and then kind of trickle that down the line. So their potential donor could then give it to another person that they don't know. And sometimes those chains can go on, through quite a few donor recipient pools. Usually the old kidney is left in place for the recipient unless there's some reason that it needs to be removed. And the survival of the kidney depends on being able to effectively block the immune response. So the host wants to reject this graft of a new kidney, and because it's a foreign object in a new body, and the body that it's in doesn't want it. It's not from there. It doesn't like it. It recognizes it as foreign. And so there's this lifelong commitment to immunosuppressing the recipient's body against the donated organ. Usually there's some sort of steroid use for immunosuppressants. Not always. There's lots of different medications these days for immunosuppressive agents, but often early on, especially, steroids are used, and any type of immunosuppressant agent leads the recipient to be at a higher rate of infection risk, higher risk infection rate. They're at more risk for infection.
Sorry, could you speak to the rationale behind leaving the old kidney in? Is it due to just the vasculature or the adrenal gland placement?
I think it's due to a number of things. One being the adrenal gland placement. One being it's another place to have to anastomose or sew off vascular tissue. I don't know exactly 100% why it is left, but I think it is less it provides less area of complication if it stays in place. Of course, it's going to be removed if it was complicating their health otherwise. So if it's infected or there's some other reason why it needs to go, it'll be removed. But if it just stopped functioning, it will be left in place.
Thank you.
They nestle this other one down kind of in the ileum. I think that one important thing to remember, both in preoperative care and postoperative care, is that you have two patients. There's not now just one patient. You have two patients, you have the donor and the recipient. Oftentimes the pain for the donor is worse than the pain for the recipient, and the return to function can be fairly long for someone who donates. It can be 6 to 12 weeks before they can be fully back to work and kind of fully functioning. So their experience is not, as a live donor, is not insignificant. There are concerns. So we hope that the new kidney, you put it in and it starts functioning right away. Sometimes there's a huge outflow of urine right away. Sometimes it can take a little bit of time, up to a few days or even a little bit longer. Some patients who receive kidneys may need to be on dialysis for a little bit of time while the kidney kind of gets online. It really depends a lot on the health of the kidney that they received. And that can be very distressing for someone who just received a kidney and is hoping like everything's going to be great. And then all of a sudden they're like, ooh, I still have to be on dialysis for a bit, and maybe it won't take. The main issue is rejection. Hyperacute rejection occurs usually within 24 hours. And when that happens, it's not reversible. There's some sort of underlying antibody against the organ right away. And that can't be reversed. And so they need to just go ahead and take it back out, unfortunately. Acute rejection happens within the first 6 months. And usually that's reversible with immunosuppressives and adding monoclonal antibodies on board. And sometimes those can be tapered off after a period of time, but they could progress to a prolonged rejection, which is when someone has acute rejection repeatedly. Or someone just has this kind of prolonged and ongoing chronic sort of slow rejection. Either way, it's building up scarring and fibrosis in the new organ, and the function declines over time. Immunosuppressive agents that are used are preventing the body from performing this cell-mediated attack against this foreign organ. And without immunosuppressive agents on board forever, the body will, if someone misses doses of their immunosuppressant agent, their body is going to pretty much immediately start attacking this foreign organ, the kidney, the liver, the heart, doesn't matter what that is. In a solid organ transplant, the host, so the recipient, rejects this, organ that's new to them. It's different in someone who is receiving not a solid organ transplant, but like a stem cell or bone marrow. In those cases, the graft, the marrow that this person is receiving is actually rejecting the host in which it's being put into. So there's two kind of different functions that can happen between solid organ and stem cell transplants. There is a lot of preparation, psychosocial preparation involved, both for the recipient and for the donor, both for, kind of anticipating risks that can happen, anticipating long-term sequelae that can happen on both ends. And then there's always a risk of infection that we would like to avoid or prevent. And there's a risk of infection both because of the surgery and a risk of infection because they're being immunosuppressed and don't fight infection as well. Nursing implications right away. You're going to be watching for these signs and symptoms of rejection. Like I said, the hyperacute one is going to be happening immediately. It can take a little while before the new kidney starts functioning. And so they may be oliguric early on. That doesn't necessarily mean they're rejecting. It just may mean that the renal tubules are, just need a minute just to kind of get their stuff together before they can start concentrating urine. But we certainly want to be measuring that and monitoring for that. They may actually have this massive amount of diuresis right away too. And so you can see kind of either of those things that happen. Any questions about this stuff? You guys want a minute?
I'm good.
Okay.
I'm good.
I'm not good. Sorry. Where did my presentation go? I don't know why I don't see my link on here. Oh, I know. Sorry. Well, that didn't happen. Am I?
Good grammar and spelling.
I'm going to go back to screen sharing.
Are important, but if you want to write essays that inspire, messages that forge brighter connections, and emails that get the job done, you need to think about more than just grammar and spelling.
I'm just going to leave this because Grammarly is so
grammatically
important.
correct.
Thank you. So it's really great to be back at the bigger, better, more exciting TEDx, having been a participant in the first TEDx 2 years ago. It was actually an accidental TEDx talk on my part because I stood in 12 hours before the event because another speaker had actually dropped out. And I think that was it was actually quite easy for me because when you stand in with 12 hours to go, you can only wing it, and winging it I'm quite happy doing. When you have several months to prepare, you think, oh, I have to actually think about what I'm going to say. My preparation for the first talk was basically, what am I going to wear? And for this talk, I'm thinking, what am I going to say now? Because I said it all before. But anyway, as Chris mentioned, I am a self-appointed queen of dialysis. I like to rule my dialysis machine. I went into kidney failure when I was 14 years old, which is 19 years ago now, and I can't have a kidney transplant. So I live and survive by dialyzing myself on this beautiful, huge dialysis machine pretty much every night at home overnight while I sleep, carefully supervised by Archie the cat. In my previous talk, I'm not going to obviously cover it again, but I talked about the fact that for many dialysis patients, kidney disease is really, really tough. When your kidneys fail, it isn't just that your body can no longer clean the blood and actually remove toxins that keep the kidneys keep you alive, but it's not just that. Your kidneys interact with all the systems and all the organs in your body. So they affect your bones, they affect your brain, your memory, your concentration, they affect your digestion, they affect your joints, they massively affect your energy. So people with kidney disease are chronically fatigued and yet they don't look ill. And that's one of the challenges. And actually, when I spoke at the original TED conference, I talked about how lucky I am to do my dialysis at home and to be able to do 6 or 7 hours every night, as compared to the people who have to go to hospital and they can only do 4 hours 3 times a week. So that's having some level of kidney function for 4 hours, 3 times a week. The rest of the time, their body is just accumulating toxins and they just feel awful, but they don't look ill. And it's really quite challenging for them to sort of try and survive and function and get on with everyday life when they're managing with this really tough disease. And one of the last TED Talk was that was the first time I went onto a really public, quite high profile platform and shared my story of doing home dialysis and how lucky I am and what a great experience I have of dialyzing in that way. And it put me in touch with a lot of kidney patients all around the world, in fact, who found the talk and contacted me and shared their stories. And it was very humbling and very inspiring to hear from different people who are all managing with this disease. And you are always a kidney patient. So we all hear about the organ donation list and everybody appealing for people to become donors. But even if you have a kidney transplant, it doesn't fix everything. Hopefully it will be great and you will do really well, but that transplant probably won't last forever. And you will be taking an awful lot of very aggressive, strong medication to keep the transplant working. So even when you have a transplant, it's not a solution. So kidney patients, they're a tough crowd. They're really strong, really positive people, and they're dealing with a lot. And actually, it's also a fairly hidden disease, but it's more common than you think. So probably most people here, or maybe you yourselves, may have some degree of kidney disease and may have some awareness of this. So my last talk was really enlightening for me when I thought, actually, I am so passionate about spreading the message about kidney awareness and about home dialysis, and I want to help more patients to feel empowered to care for themselves. Home dialysis is fairly scary as a thought. As you can see, it's a complicated machine. Your blood is in the machine going around a pump all night. You've got needles in your arm. You do feel, that's fairly vulnerable. There are lots of things that you feel could go wrong. So for a lot of patients, home dialysis is a fairly daunting prospect. And a lot of them aren't even offered the choice for various reasons. Their unit or their hospital just don't offer them that opportunity. So I made a lot of big changes and big decisions in the last couple of years since I was last at TEDx. And the first being, I had a great job, a great career in investment banking, which I loved. And I kind of thought that was what I was going to keep doing. But I found myself desperately trying to find more and more time to talk with patients, to work with the NHS to improve things for patients, and campaigning to raise awareness. So eventually I felt that's actually probably what I should be doing full time with my life. And I needed to change work in order to accommodate that. So I left my job in the city and I set up as a consultant to be able to work both in the world of kidney medicine, but also continue to do what I did as a day job, which was working in talent development and diversity. And it struck me pretty quickly that once I left my job in London, if you're going to be a consultant and be freelance, you don't have to live in London anymore. So this born and bred London girl from Peckham moved here. And that was a sort of slightly unexpected side effect of moving out of London, is that I found a completely different way of life. And I went from being an absolute city girl, party girl, burning the candle at both ends, probably pushing myself a little bit too hard and trying to go 110% all the time, to finding some peace and tranquility in beautiful surroundings, away from the city and away from some of that kind of high pressure environment that I think was a little bit a victim of. I've spent my entire life trying to prove a point that I am not sick and I'm not a patient and I don't have any problems that I have to deal with. So I'll try and do everything that everybody else does and more. And I think I have finally learned that it's okay to step back a little, take a bit of time and really focus on what you want out of life and try and kind of remove all of that noise and that pressure that was surrounding me. So leaving London was actually one of the best things I possibly could have done. I also learned a few things, such as the car thieves look a little bit different in the countryside. So that's Brenda, who lives where I live, and she just checks the car over for me every now and then. So here I was, I had no job. I had the prospect of potential clients who I could work with, and I had this wonderful home in the peace and quiet of the countryside. And so very excitingly, the first piece of work that I've been involved with, and just for a year now, is involved in becoming a patient advocate for this amazing new dialysis machine. Now, just to remind you, this is my dialysis machine. That's actually about 25 years old, probably, that machine. But the technology hasn't really changed much in the time since I've certainly started dialyzing. And then we have this, which is called the Self-Care Plus. And this machine is really exciting. It's been designed to be used by patients primarily at home, or for patients who wish to care for themselves in centre dialysis. It has 2 buttons on the front instead of around 45 buttons on the front. It does exactly the same treatment. It works in exactly the same way, but I would feel quite happy having that in my home. It looks a little bit like a coffee machine or a fridge, rather than an enormous Dalek with tubes coming everywhere. So one of the big obstacles that patients say is they don't want a massive medical device in their home. They really find that off-putting. And so I'm really excited to be involved with the project that will be launching this machine, hopefully towards the end of this year in the UK, and then round to other countries in the coming years, to really encourage more patients and make it easier for them to dialyse themselves at home. And once you start dialysing yourself at home, you can dialyse more often for more hours, and your health will have a complete turnaround. And the difference in your life, enabling you to look at getting back into employment, spending time with your family, pursuing your hobbies, going back to getting fit, just doing something really normal, like getting up in the morning and having the energy to go supermarket shopping and come home and put the shopping away and then cook dinner. Those sort of things are really often out of reach for the patients who only have their dialysis 3 times a week in hospital. And those patients don't want pity. They don't want people to think, oh, you're really sick, poor you. They don't want everybody looking after them, but they do want empathy, and they want support, and they want solutions so that they can get their lives back on track. And I believe that this machine is going to make a huge difference to people's lives. The second really exciting thing for me is that I was not that long ago approached by a very inspiring gentleman whose wife had, in the last sort of 6 to 8 months, very suddenly gone into kidney failure. And he had been plunged with her into this whole world of kidney disease, having no experience of it whatsoever before, and was very shocked at the lack of information and lack of support that was available, both to her as a new patient and to him as her carer. Now, his background is in education, in social enterprise, and in technology. And he wanted to bring all of this knowledge and experience that he had into the world of kidney disease. And somebody put him in touch with me and said that I was seeking to also do the same in terms of patient education and changing patients' lives. And so I'm really, really lucky that we met each other, and his ideas have become the inspiration to Make Someone Smile. And Polly already talked about making people smile. And I think that's a theme when you're looking at people who have chronic conditions, people who are living perhaps quite a tough life, is that there are some very simple things you can do to really change their lives. So Make Someone Smile is still a baby. We're still growing and working out what we want to do with it. But primarily, we want to focus on patients holistically. So they get their treatment and they get their blood test results, and they have the doctors telling them this is wrong and this is good and here's how we're going to treat you. But what they don't get is people saying, how's work? How are you talking to your new employer about your kidney health? How do you explain dialysis to people who you meet when you're going on a date in a bar? How do you find out how to cook the really, really, really strict renal diet so you can actually still make nice food and not have to think, I really don't want to eat anything today because the food I'm allowed to eat is just, there's no point. How do you, as a young adult, come to terms with having this chronic condition for the rest of your life, but still achieve your ambitions, still go traveling, still aspire to the job and the education that you want to achieve? And none of that is really out there. There is some great stuff going on in pockets around the UK and in the world at large, but there isn't a very consistent approach. And many patients struggle to find the information that they need. So through Make Someone Smile, we want to create resources and tools that will help people find information to help them live their lives. We want to connect patients together, especially young adults, so they feel that they are not the only person who is living with this disease and struggling often day to day. And we want to actually ultimately also have an input into the design of healthcare services such as dialysis, so that they can be made more patient-centric and more about the people and the individuals who are involved. And the most exciting thing is when we launched, we were able to work with the Duke of Edinburgh scheme to offer the first Duke of Edinburgh program specifically for people with a chronic condition. So we have the Duke of Edinburgh for young adults with kidney disease. And the program's been launched, and we're looking at recruiting young adults at the moment so they can go through that and develop skills and have some accredited skills to leave at the end of the program, like all the other young adults and their peers who don't have kidney conditions. So that's really exciting. And I think for me, it's really, it's been empowering to know that through leaving what I used to do and setting out kind of on my own, suddenly all these opportunities were there for the taking, and there are people out there who share an ambition. And if you actually talk to people and say yes to everything and follow all these pathways of opportunity, and all these things kind of have materialized over the last year. And actually, I feel like it's quite surreal in a way how much my life has changed, but it has gone in a direction where I am so lucky that the things I'm doing day to day I'm really passionate about, and I get to work with other patients and actually see how inspiring they are and how they are surviving and ploughing on despite some of the challenges that face them. And so in my last talk, I also mentioned that having a chronic condition and keeping myself alive on a machine every day has somehow driven me to seek out the most dangerous activities I can possibly find in my spare time. So skydiving is my absolute passion, and I spoke about the fact that I started skydiving 2 or 3 years ago, and I've done over 300 jumps now, and I continue to be very lucky in that I can have the opportunity to travel and to jump in other countries as much as possible, and I cannot explain how liberating it is to fling yourself out of a perfectly good aeroplane and then survive that and land and go back up and do it again. I also really try to push my physical fitness. I think when you have a chronic condition, again, that's something which often has to kind of go by the wayside, and people don't tend to advise you about the health and fitness you can pursue. Most often as a kidney patient, you're told, don't do this, you can't do that, that's dangerous, this will interact with your treatment or your medication. And I have to hold my hands up. Most of the things that I choose to go and do are not advisable to kidney patients. And I would say borderline a little bit reckless, and I'm happy to take full responsibility for my choices. But I have to say, it is great when you can still maintain a level of fitness and work hard and actually train for things where you can really test your physical fitness despite the challenges that your body is going through. Being able to do that actually gives me something to work towards. And on the days when you don't feel quite so good, you think, actually, I have to get up, I have to go, because I've set myself a challenge of doing this activity or that event, or just, you know, I've got to get through 12 skydives at the weekend, and that's quite physically challenging too. So I think that that's something that really does keep me going, and it gives me a lot of inspiration to sort of travel and still have to dialyze when I travel and go and find somewhere in the destination that I'm going to book dialysis and turn up at a strange hospital where you don't speak the language and you have no idea how it's going to work. That in itself, I actually find quite exciting. So I'm a bit weird. So I guess for me, what I really want to continue pursuing are things that give me joy every day. I am very aware in a really positive way that life is so delicate. If I didn't have dialysis, I wouldn't be here. Within 5 days to a week, I'd be dead. And that sounds quite stark, but actually for me that's a really, really motivating thing, and it makes me incredibly thankful and incredibly grateful to be here and to have opportunities to do the things that I do. So in terms of the next year, I'm lucky enough to now be part of the Formation skydiving team with these lovely ladies here, and we are entering the rookie category at the UK Skydiving Championships this summer. We do a lot of laughing and less beautiful to skydiving because we're too busy laughing, but we're going to give it our best shot. And in rookie, it's lovely because it's open to anyone who wants to enter, and it's for all people who are new to the sport, and you can have fun and learn so much. So we're going to enter the competition this summer. And then the second thing, and this I almost don't want to put out into the public sphere, but I'm going to say it anyway. My dad, who's in the picture here, he actually donated his kidney to me about 12 years ago in an attempted transplant, which sadly didn't work because my immune system immediately rejected the kidney. So he has one kidney, and I hope he doesn't mind me saying he is over 70, and he decided to just do his first marathon, which he wandered along and did very calmly and in a very relaxed fashion. And he did good training, but really inspired me. He is here, but I can't see because it's dark. So he's in the room. Really, really inspired me to think, wow, okay, he's just gone and run a marathon. And I'm a little bit competitive as well. So for my 20-year dialysis anniversary next year, I have entered the London Marathon. I hate running. I'm not Dame Kelly Holmes. I've never run anything in my life before. So that's a real, real challenge, but I'm also quite excited to think I might possibly cross that finish line. So that's my goal for the next year, and perhaps at a future TEDx event, I'll let you know if it actually happened. Thank you.
Okay, so I am trying to find where my video is. There we go. Okay, hi. I play that because for a couple of reasons. It's certainly inspiring, right, that she's been so healthy and successful despite having a chronic kidney disease, and now needs to survive, right, using dialysis every day. But I more played that because it speaks to the nursing aspect, the nursing role. What she's asking for and what she's trying to create is what nursing is really all about. So trying to help people become functional to the best of their ability, to advocate for them, so that they can achieve their highest functional goals. And for whatever, however that works, nursing is kind of in that best position, really, to take on that role. That is the role that we have. Sometimes we do it really well, and sometimes we don't. But what she talks about most, not only is the part where she got successfully, treated and in her early years, and sent home on dialysis. What she talks about mostly now is all of her needs to be functionally autonomous, and we can help her do that. I think we can help. They do, she's doing this in the UK, and they have a bunch of different programs in the UK for people to be autonomous and very independent with dialysis. But that is definitely something that can be advocated for here as well. Okay, I have a case study for you. Anybody have any thoughts about that or want to share anything about that?
I have some thoughts, but I think it was really positive. When I think about it, in some ways her situation's a little bit might be different. She obviously didn't get fully into how she went into chronic, into failure. But it is kind of a different situation when like when you kind of have someone who's 40 or 50 and it's related to hypertension or diabetes, and it's not, by no means is it a reasonable outcome of that disease process, but it is a disease process of progression where there's a lack of intervention. And so it's an interesting kind of comparison between someone who maybe didn't have like this long ongoing disease progression and a slow decline, and where it wasn't choice after choice to not manage potentially. Now that's not all, end stage renal failure. So because I was asking myself, like, well, why is it that that's not what I see in the hospital? And so it just seems, the ideal reality is her, right? Is to have them seeing it still as like a possibility to live out life and have goals. And but sometimes that's not always like reflective of what you see. But I think sometimes that's also like a lack of treatment related to the depression, related to the alteration of life. And I don't know, those are just my thoughts, and I could say a lot more, but I think all the cohort knows that I could always talk a lot.
Any comments about that or other comments?
I did like that she talked about different charities to help. And I think kind of what Alyssa talked about, different opportunities for patients. Some people can't afford to do dialysis the same way she does. Some people have to have hemodialysis, some people can't. They don't have all the options. It's great to go out and skydive. You have the time and the money and the affordability. And so, unfortunately, where the rubber meets the road is, can they do that? Do they have the time? Do they have the money, the energy, the means? What can we do to help find them resources so they can get out and they have a life to live? Because their money does get sucked up doing this. So, what can we do to help them have a life outside the hospital, but also be able to afford said life and their life-saving treatment. So it's kind of a catch-22.
Mm-hmm.
I think things might have been easier over in the UK because how their healthcare system is set up. Everyone kind of gets like a basic level of healthcare, even though it's paid through, I think it was taxation, kind of covers it with the NHS. But that's at risk now because of the political reasons. So they might soon be in the situation we're in the United States if that legislation gets passed and they destroy the NHS. So it's kind of like tenuous right now.
Yeah, and we have to hope His Majesty's or His Royal Highness's charity continues even after his passing. I mean, I'm hoping somebody will pick it up, but
I mean, I think while she was discussing kind of broad sweeping, very adventurous, embracing of her life, right? That's not to suggest that everybody who has end-stage renal disease or is on dialysis needs to be risk takers or learn a new sport or skill or go jump out of an airplane, right? Those are kind of that's very specific to what her needs are and where she is in her life. But certainly it also speaks to what we talked about last week when I talked about palliative care, right? It's finding that area of hope for patients. So whatever that may be. So I think we need to be careful, Alyssa and Sophia, making judgments about what people are capable of financially or emotionally or mentally, really, and help them figure that out. So somebody who has chronic underlying disease that has led them into this state of being where they now are required to be on dialysis, they now have end-stage renal disease, this could be a huge turning point for them. And it could be a positive turning point if they can be helped, if we can help facilitate them seeing it that way, even if it inherently looks very negative from the surface. And so kind of meeting patients where they're at and helping guide them into a positive place is really helpful. Maybe it's just a kind word or an opportunity or a resource, Sophia, just like you were saying, to something that can help be motivating and very positive, reinforcing really positive behaviors. But if we treat them like, ugh, well, you're never going to be able to afford to go outside again, good luck with that, then that's their takeaway, right? But if there is other opportunities or options, helping them lead their best autonomous life, whatever that may be, people can learn how to take control and really want to take control out of their own whatever they have left of their life. And not everybody, but certainly a lot of people. So I have a case study. And it is on Blackboard under case studies. I'm going to put you into groups. I want you to work on it for about 20 minutes. We won't have a ton of time to discuss it. I actually just want you to have more time just to like work on it in your group. And so I'm going to put you in one. It should be open to anyone. You don't have to have a UA ID, I don't think. It will ask you for your email. Just one person per group can submit it, please. I guess it doesn't matter, but if you submit it and there's a little slider on the bottom of the form, it'll ask you if you want to get emailed a copy. Then do that. That way you can see what the responses are and I can see them too. All right, I'm sending you to a group. You will have 20 minutes. Anybody learn anything?
Yeah.
Did anybody get really stuck anywhere?
We kind of debated about the main cause being the heart failure, which would be pre-renal or being intrarenal from hypertension and diabetes.
Mm.
We kind of went back and forth about that.
What did other people come up with there? Let's get that.
Well, we just really spent a lot of time going around the block on it all because I guess the answer is I didn't know the answer. Because I thought, well, is it possible that the heart failure is from the fluid retention because of the kidney damage? That, you know, if you start to have that fluid buildup, we know the heart will kind of start to change with it. But she had all the signs and symptoms for heart failure, but she also had what I saw as like a positive infection in her urine analysis with the protein and the CAS. So I don't know.
So go ahead.
I was gonna say, we were looking at our UA, and I found in the book it says your analysis with abundant cells, casts, or proteins suggests intrarenal disorders. So we kind of danced around, and then we found that, and I think we talked about. It says she has a long history of heart failure and hypertension, and we thought the hypertension might be what was causing a lot of the intrarenal issues.
Okay. Any other thoughts about that? I have a lot of thoughts, but I'd like to hear from you. I think one thing to consider in my thought process here is that early on when we were talking about acute kidney injury, well, I guess unfortunately people aren't, people come with all of their chronic disease baggage, right? It's not like somebody comes in usually with just this one thing and then that's that, especially when people, as people get older. And so earlier in the acute kidney injury presentation, I talked about how somebody can have a chronic underlying kidney problem and have an acute disease process on top of that, an acute on chronic. And I think that, I think you identified through your groups, it sounded like the reasons why that's the case. She probably does have some intrarenal injury because she has chronic hypertension and she's spilling proteins in her urine. But she has this right-sided heart failure right now. And so she's not perfusing her kidney very well, which is inherently a pre-renal kidney injury and probably more acutely happening on top of her chronic disease process. I want you to try to remember, if you don't already, what does it mean when why is somebody losing protein in their urine, and what are casts?
Casts are like the bacteria.
Are they though?
Okay, I guess that means no.
They're not. Yeah, they're not. Anybody know what they are?
Aren't they made up of like white blood cells or red blood cells or protein or fat? They're like little tube-shaped particles.
Yeah, they're literally like little casts of the tubules. So they're clusters of cells that are because they're clustered together. We'll talk about why they're being clustered together or how they can even be that way. But they're clustered together and they're being squeezed into these really tight spaces of the tubules. And so they make this cast basically of the tubule shape. And then they're squished through and peed out. The reason that they come to be there is the reason why proteins can be in your urine too. How do proteins get into your urine? Are they supposed to be there?
No, isn't it like a damaged basement membrane in your glomerulus? Or it's like, essentially, they're fairly large, so your basement membrane has to be damaged. Or
some proteins are
let them through, essentially.
Right. Some proteins are large, some are not. But yes, even if they're not large, proteins should be secreted back into the vascular space. And if they are large and they're escaping through the glomerulus basement membrane, there's a problem with the podocytes or the basement membrane of the glomerulus. And so that in and of itself, if you have proteinuria in urine, you know there's something wrong with the glomeruli, at least enough of them that they're secreting, that they're, you know, that the glomerulus is letting proteins filter through. And because it's letting proteins or other large molecules filter through, that's how you can end up with these clusters that are kind of big cell clusters that get squeezed through the tubules and then get released in urine in that little tubule shape. What other areas did you get stuck on? It's actually 301, so feel free to go. Before you go, if you're still here, if you submit the form, it will email it. A copy will be emailed to you, and there is feedback in the process of that. So there's like the answers, which may or may not be like all of the answers in all the land, but you know, kind of the train of thought that I'm hoping that you were getting is written in there. So you get some feedback about what yeah, kind of what the course was or expected to be.
If I have to go and I finish filling that out later, is that okay?
Oh yeah, absolutely. Yep. Yeah, it's open and you can, your group, if you guys filled it out together, you can kind of share the one you filled out when you get the email response back by email, or you can refill it out and just put like X's in all the spaces if you don't want to go through it, and if you submit it, you'll get a feedback form back.
Okay, thanks. I really appreciate it. I wish I could stay for the conversation.
Oh,
Judy's call. So thank you.
Yeah. While you were gone, I got a call from the Social Security Administration telling me that they needed all of my money right now, and so I sent it all to them.
I'm like 10 of those this week. It's so rude. I got to go to his office, Social Security. I'm like, get lost.
I tried to keep somebody on the line yesterday about it, just to hassle them a little, but they ultimately.
I'm gonna get super mad at you too and call you names. You called me, not the other way around.
That happened to me too, Christina. I kept the person on the line, and then they were like, "Hey, you don't ask the questions. I ask the questions." I'm like, get lost. You're a freaking hacker.
Yeah, they've cussed me out before.
They scammed my grandma out of 14 grand.
I know, it's terrible. It is so terrible. Ugh.
So fortunately, my dad's a lawyer and he's going after them for like everything that he can. But yeah, it's been a long week.
They're spoofing all these 907 numbers, so they look very familiar. It can be very tricky. Anyway, sorry, I derailed that.
These are the kind of conversations that would happen if we were actually live. So
yeah,
normal.
Any other stuff that came up while you were doing the case that was problematic or you're not sure about, or want to talk out with other people or me? There was a lot of labs that kind of popped into each group, and people were sort of teasing out the labs. I think that some of these things in the case are helping you understand things that you might need to study more or get more understanding of, specific to kidney function clearly, and that's great too, right? So that's kind of how case studies can be helpful in that way, sort of highlighting things that you're like, ooh, I don't actually know that very well, so I probably should look it up. But any other stuff that we should review about the case?
Did
or the lecture
and the hemoglobin in the case study, did those mean anything? I wasn't really able to make the connection, I guess, for myself of whether that would be impacted by kidney failure or if that's something else. I could see that one of them was low.
Yeah, so she has this. Well, what are other people's thoughts about that? I don't need to be the one that has to talk.
It said she had red blood cells in her urine. I mean, it didn't specifically say hematuria.
But that is hematuria.
But yeah, so that could be part of her blood loss.
And I think Kaylee also mentioned in our group anemia.
And why would she have anemia?
If her kidneys are jacked up, they're not making the red blood cells. They're not making the erythropoietin that would make you make the red blood cells.
That's certainly one reason for sure. So if she has this underlying, her acute kidney injury isn't going to be doing that, but if she has like this kind of chronic underlying kidney injury, we know she has hypertension and she has proteinuria, and she has a little bit of hematuria. So yes, we can assume that maybe she's not making as much erythropoietin as, you know, somebody who doesn't have all of those things going on. But what's another reason that she might be anemic?
She might be excreting too much or not reabsorbing enough iron.
She could be iron deficient, certainly, or nutritionally deficient. My thought process here is that we know that she's a little bit older. We know she has these underlying chronic diseases, and it's very, very common. There's something called anemia of chronic disease. That's a real thing. And so she likely has this baseline anemia of chronic disease going on. So she's always just sort of running low.
So I had a question about the casting. Could that be from her hypertension? And I was curious, like, it didn't really say if her diabetes or her hypertension were being managed or if they were being managed well.
Right. I don't even know. So yes, the first part of the question, her proteinuria is certainly from her hypertension. Is that what you were asking?
Okay.
Or the casts?
Yeah, I was thinking that the casting would be because of mismanaged or unmanaged hypertension.
Yeah. So if you have, so just like your glomerular filtration rate can be low from lack of perfusion, if that glomerulus is under chronic high pressure, it's just going to shove stuff through the glomerulus. So you can end up shoving larger cells through the glomerulus, and therefore some of those proteins, and you're doing that chronically, you're damaging that basement membrane like we talked about, the podocytes, and that's going to let some of those larger molecules through, including proteins, which is why you see microalbumin, you see albumin in the urine or protein in the urine.
Gotcha.
Yep. And while it's doing that, it's causing little micro tears in the tubules and all along the way. And so that's where that's usually where the red blood cells are coming from. If you're seeing red blood cells in urine, that's not gross hematuria. Then just on the micro exam, that's from tiny little damages along the way, usually, or urinary tract infection.
Oh, okay. So I stepped away for a minute, so my apologies if I missed this part, but so I was trying to put it all together for the case study, and so the reason why I brought up like mismanaged or unmanaged diabetes or hypertension is, my thought is that the hypertension and the diabetes could definitely have caused damage to the point where when her heart failure started becoming more of a problem or more like advanced in its process, her kidneys just couldn't deal with like the little bit of like lack of perfusion. Is that right?
I think that's right. Does everybody else think that's right too? I think that, yeah, I think you're spot on there. She's kind of got some kidneys that are already under duress, and then she's making them more under duress. Mm-hmm.
Cool.
Anything else? Nap time's over, Daryl.
She woke up in not the best mood either. So I'm like, gummy bear, a show? Great. Just let me a few more minutes.
That's the worst. Naps are supposed to make them feel better. It's horrible when they wake up grouchy.
She was pumped when I went down there, and then I don't know if I brought her upstairs too soon, too quickly. I don't know. I didn't give her the choice. I didn't let her say, let's go upstairs. Who knows? It's a mind game that I constantly lose at.
Mm-hmm.
You're still a winner to us, Daryl.
Well, I don't need to keep you. So what did I get here? Oh gosh, I got my bill from paying off my Social Security. Just kidding. Oh, cool.
Thank you, Heidi.
Thanks, you guys. Yeah,
Thank you.
if you end up having questions after you submit the case study, you can let me know.
Thank you. Were we
Okay.
supposed to get like an answer sheet with it? Because when
Yes.
I emailed it just like sent back what we had wrote.
It didn't send the feedback.
Maybe because we didn't fill out the whole thing? I'm not seeing any feedback at least.
Is this the one that got emailed back to you?
Yeah. Oh wait. Oh no. Yeah. So I just got kicked back everything that we had submitted. And maybe it's because we didn't fill out the whole thing, but I don't have any feedback on it.
Okay. Can you do me a favor? I know you're busy because you have a kid right there, but if you open it and you just hit just put an X in each thing and then submit it. Can you tell me if that gives you feedback?
Yes. Let's see.
Otherwise, I'll just post the feedback separately.
Okay. Send me a copy. What do you see? All right. I got the new one. Excuse you, don't fart on me.
She is so cute, Daryl.
Yeah, it is a riot.
She's like a mini you.
That's what everybody says. Okay, so I did not get any feedback on the main one. View score 0 out of 0, but no feedback. And then there's one other.
What? Okay, I'll just send it separate.
I don't think I'm getting any feedback on it.
Okay, well, that's lame.
Glad I asked because I was like, oh, maybe I had sent it to Nikki and Hannah. I forwarded it along and I was like, wait, I don't see anything.
Okay, I'll just post it in the same place the case was found.
Okay. Could you just send out an email and let us know when you did that?
Yeah.
Okay, cool. Thank you.
Okay, thanks.
Bye.
Bye.